Hello, everyone. Today, we're tackling a question that haunts athletes, coaches, and sports medicine professionals everywhere. Why do some athletes keep getting injured in the same place over and over again? You work hard in rehab. You get clearance to return to play, and then boom, the same injury comes back. It's devastating, it's frustrating, and it feels inevitable. But here's what most people don't understand. The problem isn't bad luck. It's not that you didn't stretch enough or didn't build enough strength. The real culprit is something invisible that's been hiding in plain sight all along: movement errors. Let me start with some sobering statistics. Research shows that injury recurrence rates can reach 40 to 70% for certain injuries like ankle sprains. Think about that. If you've sprained your ankle once, there's a better than 50-50 chance you'll do it again. For ACL tears, hamstring strains, and shoulder injuries, the numbers are similarly disturbing. And the standard explanation we've been given for decades is incomplete: recovery or insufficient training. But that's not the whole story. Here's what's actually happening. During injury recovery, your body develops compensatory movement patterns to avoid pain and work around limitations. This is a natural protective response. But here's the problem. These compensations become habitual. They persist long after the pain is gone and the tissue has healed. Your original movement chain is disrupted and never properly restored. So when you return to sport, you're moving with fundamentally flawed mechanics that you can't even perceive. This invisible movement dysfunction is what sets you up for re-injury. Let me give you a concrete example. An athlete tears their left ACL, goes through surgery and rehab, regains strength and range of motion, passes all the standard return-to-sport tests, and gets cleared to play. But here's what the tests didn't catch. During recovery, they unconsciously started shifting more weight onto their right leg during cutting and landing. Their brain created this compensation to protect the healing left knee. Months later, this pattern is deeply ingrained. The left hip stabilizers aren't firing properly anymore. The left knee collapses inward slightly during deceleration, and the right side is now chronically overloaded. What happens next? Either the left knee fails again under the same faulty mechanics, or the right knee, hip, or lower back breaks down from excessive stress. Either way, another injury. This brings us to a critical concept: functional recovery and movement. Quality recovery are two completely different things. Most rehabilitation focuses on restoring range of motion, strength, and basic function. Can you squat? Can you jump? Can you run? Check, check, check. But almost no one is asking, how are you squatting? How are you landing? How is force being distributed through your kinetic chain? The devil is in these details. Research by Hewett and colleagues in 2005 showed that poor landing mechanics, specifically dynamic knee valgus, where the knee collapses inward, is strongly predictive of ACL injury in female athletes. This isn't about weak quadriceps. It's about faulty motor control patterns, originating in the brain and nervous system. The movement error exists at the level of neural programming, not just muscular strength. So what exactly is a movement error? It's a deviation from optimal motor patterns and coordination. It's inefficient biomechanically, suboptimal movement that increases tissue stress. Common examples include knee-dominant landing instead of using hip strategy, excessive lumbar extension due to core instability, foot overpronation from collapsed medial arch, and compensatory upper body movement to make up for lower body deficits. These aren't just stylistic differences or personal quirks. They're mechanically inefficient patterns that accumulate stress on tissues and set the stage for breakdown. Here's something fascinating. These movement errors originate in the brain. Movement is controlled by a complex network involving the cerebral cortex, cerebellum, basal ganglia, and sensory input systems. When proprioception, vestibular input, and visual information aren't properly integrated, the brain can't create an accurate movement map. The result? Faulty motor commands get sent to the musculoskeletal system, creating compensatory movements that become reinforced through repetition, automated through motor learning, and eventually invisible to the athlete's conscious awareness. The most dangerous movement. Errors are the ones that have become completely automatic. The athlete has no idea they're doing anything wrong, because their nervous system has labeled this faulty pattern as correct. For example, a soccer player who always cuts on their right leg is unconsciously avoiding loading the left. A female basketball player whose knees cave inward on every landing has lost hip external rotator activation. A baseball pitcher who generates velocity, primarily with arm whip, has insufficient trunk rotation and hip extension. These patterns can't be fixed with willpower or coaching cues alone. They require neuromotor re-education. This is where movement assessment becomes absolutely critical. You can't fix what you can't see. Assessment tools like the functional movement screen, or FMS, were developed specifically to make these invisible problems visible. FMS consists of 7 fundamental movement tests that evaluate quality, asymmetry, and compensatory strategies. Research by Kiesel in 2007 found that NFL players scoring below 14 on FMS had a 2.5 times higher injury risk. Chorba's study in 2010 showed that female athletes with ACL injury history almost universally had low FMS scores. Another powerful tool is the Y-balance test, which assesses dynamic stability, balance capacity, and side-to-side differences. Pliski's research in 2006 demonstrated that athletes with more than 4 centimeters of asymmetry in Y-balance test had dramatically increased lower extremity injury risk. This is especially relevant for sports involving direction, changes like basketball, soccer, and rugby. For elite-level programs, 3-dimensional motion capture systems like Vicon provide incredibly detailed biomechanical analysis. You can quantify joint angles, velocities, accelerations, and torques with precision. You can visualize dangerous movement patterns like knee valgus during ACL injury mechanisms, compare hip-dominant versus knee-dominant jump strategies, and detect delayed trunk rotation during baseball pitching. The limitation is cost and complexity, but the insight is unparalleled. Now let's talk about sport-specific movement patterns. Different sports create different movement habits, and therefore different injury patterns. Soccer players do repetitive cutting, kicking, and single-leg support, which often creates right leg dominance in right-footed players, leading to left hip strengthening but right. Hip stability deficits, foot overpronation and inversion, control problems, and loss of hip extension strategy in favor of knee-dominant movement. Common injuries include IT band syndrome, recurrent ankle sprains, and adductor overuse. Basketball players face repeated jumping and landing, which frequently produces dynamic knee valgus on landing, insufficient core stability, leading to shoulder compensation and inadequate hip strategy during rapid direction changes. This leads to ACL tears, patellar tendinopathy, and shoulder impingement. Baseball pitchers deal with throwing arm overuse, creating excessive external rotation with internal rotator inhibition, trunk rotation asymmetry, causing lumbar stress and unilateral movement patterns disrupting hip and pelvic alignment. The result? Labral tears, UCL injuries, and lumbar stress fractures. Track sprinters have repetitive acceleration movements that can cause hip extensor overuse. With knee-dominant compensation, hamstring overactivity, combined with anterior pelvic tilt and lumbar extension, and asymmetries developing, despite seemingly symmetrical movement. They're prone to hamstring strains, lumbar hyperextension injuries, and Achilles tendinopathy. The key insight is that movement assessment should be tailored to sport-specific demands. For soccer players, emphasize single-leg squat and Y-balance asymmetry screening. For basketball players, analyze jump landing sequences carefully. For baseball players, examine pelvic and trunk rotation, timing and coordination during throwing mechanics. So how do we fix movement errors? This is where corrective exercise strategy becomes critical. The most useful framework is Gray-Cook's joint-by-joint approach, which recognizes that different joints have different primary functions. The ankle needs mobility, the knee needs stability, the hip needs mobility, The lumbar spine needs stability. The thoracic spine needs mobility. The scapula needs stability. The shoulder needs mobility. By addressing the right quality at the right joint, we can systematically correct movement dysfunction. For mobility deficits, use dynamic stretching that activates the nervous system. While increasing range, mobility drills that consciously improve joint movement and breathing coordinated movement, especially for thoracic and hip mobility. For stability deficits, focus on core stability re-education with intra-abdominal pressure control, neuromuscular control reconstruction for dynamic balance, and timing and sport-specific exercises that relearn movement patterns in context. If you found this video valuable, please give it a like and subscribe to the channel for more evidence-based insights into sports performance and injury prevention. Thank you for watching.